name is Lim TIAN. I'm a cardiologist in Singapore. I would like to share this presentation on the prevention and management of coronary artery disease. As a cardiologist, I strongly believe in prevention of heart disease. Often we get confronted if a relatively young man suddenly dies on the soccer field, or a middle-aged man suddenly dies during a run. I often get patients who are afraid then that they might have a similar problem. Now, I just want to talk a little bit about the anatomy of the heart. The heart has three major arteries, and these arteries can get a blockage over time. We call that an atheroma. And these blockages will take many, many years to develop. But a heart disease can strike suddenly. You do not need to have a 90% blockage to get a heart attack. You can get a 30% blockage and have a heart attack. And the mechanism is plaque rupture. Yeah? So the plaque ruptures, fat content comes out, mixes with the blood, and you get a blood clot, and suddenly from a, let's say, a 30% blockage, you get a 100% blockage, and thus a heart attack. In Vietnam, the number 2 cause of death is a heart attack, and it's fatal in 30% of the cases. What you need to realize is that 50% of the deaths occur within the first hour of a heart attack. So it's very important for somebody with chest pain or suspicion of a heart attack to go to the hospital immediately. Presentation of heart disease can be as following. You may not have any symptoms, and when you go for a health screen, it is discovered that you have a blockage. Actually, in many patients, we discover a blocked artery doing a health screen. You can present as a heart attack. You suddenly get chest pain, shortness of breath, sweating, and you go to the hospital and they find that you have a blocked artery and you're going to be treated for it immediately. You can also present with symptoms. You get chest pain on exertion, yeah? You feel breathless when you climb up the stairs, or the first symptom is just feeling tired. You can also get jaw pain when you walk, or you think you've got a stomach problem, but it's actually a heart problem. You can also present with arm pain. What will cause a heart attack? What are the risk factors you can have? And I will distinguish between non-modifiable risk factors and modifiable risk factors. In the old days, we thought that men, if you're a man, you're predisposed to heart problems. But nowadays we know better that women, especially post-menopausal women, have a higher risk of heart problems than men. Age, when you get older, the risk of heart disease is higher. Race, certain races are more predisposed to coronary artery disease than other races. For instance, people from South India have extensive coronary artery disease. Family history. Let's say your father had a heart attack at the age of 50. It is possible that you will have a heart problem at a young age. Yeah? Or let's say your mother had bypass surgery at the age of 60. It is very well possible that you might have coronary artery disease at a relatively young age. Then there are the modifiable risk factors, meaning we can treat these risk factors. Diabetes is a strong risk factor. Patients with diabetes have a 48 times higher risk to develop coronary artery disease compared to non-diabetics. High blood pressure. People with high blood pressure have a 2 times higher risk of getting coronary artery disease. High cholesterol. People with high cholesterol have a 2 to 4 times higher risk of getting coronary artery disease. Smoking is a very strong risk factor. Being overweight and not doing enough exercise. And all these risk factors we can actually influence and therefore try to prevent blocked coronary arteries. This is just a graph to show that the more risk factors you have, the higher the risk. What you see here are the number of risk factors, and this is the risk. And as you can see, if you have one risk factor, the risk is like that. But if you have 3 or 4 risk factors, your risk goes up significantly. So what tests can we do to see if you may have coronary artery disease? I think the most important test is just talking to the patient, taking a history, try to find out what are his risk factors. Then we can do certain tests. We can do blood tests to check for cholesterol, blood sugar. We can do a baseline ECG. We can do a treadmill test to see if somebody does exercise, if they get chest pain, and if their ECG changes. We can do more sophisticated tests like a stress echo or nuclear scan. But the most accurate non-invasive test nowadays is a CT scan of your coronary arteries. In my opinion, you get the most information by doing a CT scan of coronary arteries in somebody with multiple risk factors. And the confirmation if somebody has a blockage is by doing a small invasive procedure called a coronary angiogram. What is the accuracy of a CT scan? The accuracy of a CT scan is as follows. If it's normal, the accuracy is about 90 to 95%. If you have blockages, the accuracy is about 80 to 90%. Patients often ask me if there's a high radiation dose. Yes, with the old generation of CT scans, there's a high radiation dose. But with the new generation CT scan of the coronary arteries, the radiation dose is fairly low, and it's like similar to a mammogram. You have to be careful with doing CT scans in patients with underlying kidney problems. These are some pictures of coronary arteries in a CT scan. You can see blockages here. You can reconstruct those pictures and get a nicer overview. This is an example of a coronary angiogram. This is a small invasive procedure where we visualize the coronary arteries by inserting a catheter and inject dye in the coronary arteries. This is just an example of the left coronary artery system, and this is normal. This is an example of the right coronary artery. There are no blockages seen. I just want to share a few cases, how people can present. One of my patients is a 40-year-old man who exercises 5 times a week. He does not have any complaints of chest pain. He does not complain of breathlessness. He smokes 1 pack a day, and his father had a heart attack at the age of 52. He came to see me for a checkup. I put him on a treadmill. He was able to run quite well, did not complain of chest pain or shortness of breath, and there were no ECG changes. What you need to realize about a treadmill test, we only pick up about 60 to 70% of the patients with coronary artery disease. Because patient was a heavy smoker and had a strong family history for heart disease, I decided to do a CT scan, and it showed 290% blockages in a major artery. Patient had a diagnostic coronary angiogram done and 2 stents were placed, and he's back to doing exercise. But this is just an example of a patient who doesn't have any symptoms, who does have multiple risk factors, and who's at risk of sudden death because he doesn't know he's got any blockages. Case number 2, a bit unusual. Usually premenopausal women are not at a high risk of heart disease. I had a 45-year-old woman who exercises regularly. She had some fake chest pain at rest but not during exercise. There were no cardiac risk factors, meaning she was not a smoker, no family history. I did a treadmill test and this was abnormal. Sometimes the treadmill test can be abnormal, and when you do another test, it's normal. So my suspicion that she had a blockage was not high, so I did a stress echo. It was normal. I decided to treat medically, but a month later, patient still complained of having some chest pain. This time I ordered a CT scan, and it showed a 90% blockage in one of the major arteries. She had a diagnostic coronary angiogram done, and she had a stent placed, and she doesn't have any symptoms now. Now, I just talked about risk factors. The questions I have is, can we influence the progression of coronary artery disease? Meaning, can we prevent coronary artery disease? And which risk factors can and should we treat? And how aggressive should we treat? I again want to show you the chart where we look at risk and the multiple cardiac risk factors. At the left, you see the risk when you have one cardiac risk factor. At the right, you see the risk when you have multiple cardiac risk factors. So the more cardiac risk factors we treat, the lower the risk is. Here's a chart where we show that how the high cholesterol in combination with high blood pressure can increase your cardiac risk. And this is a slide to show that if we treat blood pressure and cholesterol, we can reduce your risk by 65% just by treating blood pressure and just by treating cholesterol. We're not even talking about treating blood sugar or doing exercise or losing weight, just by taking pills for blood pressure and cholesterol. So what are the preventive measures we can do? Stop smoking, exercise, I mean regular exercise, minimal 150 minutes a week, which means 3 times 50 minutes or 5 times half an hour a week. Diet. Nowadays, we advise patients a low carbohydrate diet, so hardly any rice, hardly any noodles, hardly any bread. Be careful with sweet things, but you can eat meat, you can eat fat. When you're older, it's good to do regular checkups. And of course, aggressive treatment of blood pressure, cholesterol, and diabetes. Let's say you have a blocked artery. What can we do? We can do an angioplasty, which is a balloon procedure, and place a stent. This is a very relatively low risk procedure. The risk is about 0.5 to 1%. You just need to stay in hospital for 1 night. The recurrence rate of the blockage at the site of the stenting is less than 5%, and with the new generation of stents, less than 3%. The only drawback, it's costly. When we put in a stent, we use drug-eluting stents. And the first drug-eluting stents came on the market in the early 2000s. This is a picture of a second generation drug-eluting stent. You see it consists out of a coil mechanism, and on top there's a coating with a medication on top. And this medication elutes out in the vessel wall and prevents scar tissue formation. These are just pictures of what happens when you put in a stent. At the left, you see a narrowing of the coronary artery. There at the right, you see after a stent has been put in. Yeah? And further down, you see how it looks like after 6 months. The artery is still open. Even after 2 years, we see good results. If you have a lot of blockages, it might not be the best option to do stenting. A better option may be bypass surgery. Nowadays, it's a routine surgery. In somebody with a normal function of the heart, the risk is relatively small, 1 to 2%. And in patients with a poor function of the heart, it's slightly higher, 3 to 5%. Of course, compared to angioplasty, it's a bigger procedure, it's open heart surgery, and the patient needs to stay in hospital for 1 week. They're good long-term results. This is just a picture to show what bypass surgery is. For instance, you have a blockage here. A surgeon takes a vein out of the leg and bypasses from the aorta into the artery. So the conclusions, I think screening for coronary artery disease in patients with risk factors detects disease at an early stage. And then we can decide what we can do with it. We can do a lot in prevention. We have got good non-invasive imaging methods to detect coronary artery disease, and treatment of risk factors prevents progression of coronary artery disease. And if you have blockages, we have treatment methods which includes angioplasty and bypass surgery. Thank you very much.